Hello, my name is Maia Nofal. I'm a surgery resident at Boston Medical Center and a Fogarty Fellow with Stanford and Addis Ababa University. I'm going to present an abstract called Addressing Gaps in Surgical Safety Checklist Use, a statistical process control analysis of a surgical quality improvement program in Ethiopia. I don't have any disclosures. So the surgical safety checklist is a perioperative tool that has been shown to reduce morbidity and mortality from surgery. It's intended to be universal to all settings and was initially studied in a wide range of hospitals in both high and low income countries. However, challenges in uptake and compliance remain in low and middle income countries due to limitations on human resources and a lack of robust processes for implementation and auditing quality improvement initiatives. Variability in uptake is in part dependent on differences in implementation strategy, but even when resources are limited, improving compliance is still ultimately possible. In our case, the surgical safety checklist was implemented as part of a larger quality improvement program called Clean Cut. Our aim is to evaluate the rates of surgical safety checklist uptake in response to specifically educational workshops delivered as part of the Clean Cut quality improvement program. A little bit about Clean Cut. It's a 6-month adaptive program aimed at reducing surgical site infections through process mapping and facilitating locally driven initiatives for perioperative infection prevention. It focuses on 6 areas: hand washing and skin prep, antibiotic prophylaxis, sterile gowns and drapes, instrument sterility, gauze counting, and importantly, the integrated use of a surgical safety checklist. It aims to improve checklist compliance, which captures specific behavior changes. I'll explain exactly how these are defined and measured later on. The program also includes educational sessions targeted towards multidisciplinary teams, one of which focuses on addressing knowledge gaps in surgical safety checklist use. It's been implemented to date in 10 sites across Ethiopia, with notable improvements in checklist compliance. The pilot study was notable for improvement in checklist compliance from 58% to 77%, with a 45% decrease in surgical site infections. Furthermore, the improvements were sustainable 6 to 18 months after the conclusion of the program, and in some cases even improved further. Because the surgical safety checklist requires a lot of staff engagement and behavior change rather than purchasing decisions, we hypothesized that addressing knowledge gaps among staff would result in correct and more frequent use of the checklist. 5 hospitals were provided with a day-long workshop. The content included a pre- and post-test, background and history of the surgical safety checklist, key behaviors necessary for correct use, and also focused on teamwork and communication. We wanted to be able to assess the change in uptake related to the workshop. In order to address the attribution of the workshop to checklist uptake, we pursued an analysis using statistical process control methodology. This is a method principally used in manufacturing to detect changes in specific time intervals. It measures changes in variability that result from a particular action. More recently, statistical process control methodology has been applied to clinical practice and quality improvement. Through the use of rigorous time series analysis, it can detect changes in clinical performance before and after a quality improvement intervention. For example, this chart shows the example of a bundled intervention to reduce surgical site infections that used a statistical process control analysis to determine the efficacy of their intervention. Their data is represented over time on the chart with the frequency of infections on the y-axis. The vertical line represents the implementation of the intervention. The horizontal lines represent the mean rates of infections before and after the intervention, with the shaded areas representing a 95% confidence interval. As you can see, using this methodology, we're able to see the change in the frequency of infections and generally the reduced variability in infection rate. We applied the same methodology to our own quality improvement program, using the checklist workshop as the intervention of interest, measuring checklist compliance before and after the workshop. We applied this to the combined data from the 5 Ethiopian hospitals as well as to each hospital individually. We used data from 5 hospitals that were all provided with the surgical safety checklist workshop that were from the original study. The data was obtained from April 2019 to September 2020 and included 2,511 operations. Nurses were engaged as data collectors and were trained to recognize specific behaviors that meet the requirements of the checklist. The data was collected through direct observation of these behaviors in the operating room. Our primary outcome was surgical safety checklist compliance, which we defined as completing all 3 key behaviors correctly. These 3 key behaviors were signing in, which had to be done aloud and prior to anesthesia induction, timing out, which again had to be done aloud and had to review anticipated blood loss and review the procedure to be performed, and a sign out at the end of the case done aloud and in the operating room. Each behavior was meant to be specific to reduce the subjectivity of the data collectors. The operating room team was considered compliant only if all 3 of these behaviors were done correctly. Secondary outcomes include each of the 3 key behaviors, sign in, time out, and sign out, and no partial credit was given if the behavior was not done fully. For our data analysis, operations done prior to the workshop were considered pre-intervention, and those done after were considered post-intervention. We used a Poisson regression of weekly checklist compliance offset by the number of operations done per week and fit with generalized estimating equations to account for hospital clustering and in-hospital autocorrelation effects. This allowed us to calculate the incidence rate ratios, which represent the incidence of checklist use after the workshop compared to before. Because incidence rate ratios are more difficult to interpret than compliance rates, we conducted a marginal analysis that predicts the mean compliance rate pre and post-intervention. This represents the percentage of time that the checklist was used correctly before and after the workshop. We represented our final results in percentage point increase in checklist compliance. So moving on to the results, our demographic data was similar between both groups. There were slightly more urgent and emergent cases in the post-intervention group and slightly fewer obstetric cases. Here, our incidence rate ratios are represented and highlighted in blue along with confidence intervals and p-values. The incidence rate ratios greater than 1 suggest more frequent correct use of the checklist post-intervention compared to pre-intervention. When we use these values to calculate pre and post-intervention predicted compliance rates and subsequently percentage increase in checklist compliance. So this figure here represents each of our 4 outcomes. The mean compliance rate is represented on the y-axis and the pre and post-intervention time points are on the x-axis. The compliance rate at each of these points is noted on the graph. As you can see, the compliance never reaches 100%, but despite that, it does have significant improvement. Overall compliance increased 52% from 27% pre-intervention to 41% post-intervention. Each of the key behaviors also improved with the biggest improvement in the rates of sign-in with a 25% increase. Timeout improved the least, 8%, but had the highest rates of compliance prior to the workshop. While improvements in timeout and sign-out were noted, the changes were not statistically significant. While the workshop is not adequate for reaching 100% compliance, improvements were significant and mostly driven by improvements in correct sign-in. When each of the hospitals was analyzed individually, we found significant variability between the hospitals. 3 hospitals had improvements greater than 30%. Others had little to no improvement. Here's our 5 hospitals represented with the combined compliance of all hospitals represented in magenta. As you can see, 2 hospitals with little to no improvements had very low rates of checklist compliance prior to the workshop, whereas 3 hospitals with the largest improvements had higher rates of checklist compliance to begin with. A limitation of the study was a challenge with data capture. Direct observation is very time intensive and adds to the workload of the nursing staff in the operating room. Additionally, there's a risk of data collectors extrapolating data. We tried to mediate this through very specific and concrete observable behaviors to record. Finally, the Hawthorne effect could drive behavior. For this reason, we're pursuing further research via a stepwise cluster randomized approach. Finally, despite all of these improvements, we're still far from 100% compliance. We found that addressing knowledge gaps in surgical safety checklist use did improve the rates of correct usage, but was limited to hospitals that were already familiar with the checklist. Addressing knowledge gaps was not sufficient in improving the uptake of surgical safety checklist use in hospitals that did not have experience with its use. This emphasizes the importance of culture change and staff engagement in implementing the surgical safety checklist. However, in engaged facilities, a short workshop can act as a catalyst for behavior change. These are my references and questions.